Hey everybody, we're going to go ahead and get started. We do have a didactic today that I think you guys are excited to hear about. Can everybody hear me? I know I can't, I can only see one person, but let me know if you can hear me.
I can hear you.
Awesome, thank you. So we'll start with introductions and then we'll jump right into the didactic and then we'll do discussion and any questions and everything. Corey, do you mind to start with introductions?
Sure. My name is Corey Grogg. I am a women's health nurse practitioner in Glenville with Minnie Hamilton Health Systems. I'm finishing up my family practice, so I'll be finished with that in May.
Perfect. Thank you so much.
Thanks.
And then we have a phone number ending in 4478. Would you introduce yourself?
I don't know if that's me or not. This is Jennifer Thomas Christie. I'm a nurse practitioner at WVU Ruby in advanced heart failure.
Excellent. Thank you so much. And then Donna. And Donna, you are muted. And it's okay if you have trouble with the mic or anything. Everybody just chat us, and we'll see you when you chat us. Mitra, do you want to introduce yourself?
Hey guys, I'm Mitra Motasham, Project DOAC Coordinator.
Awesome. Thank you.
Thank you.
Great. And then here.
Dr. Sokas, one of the heart failure cardiologists here, run the ECHO project in cardiology. And we're lucky enough to have one of our fellows, Dr. Mohammed Osman, to present today on anticoagulation and atrial fibrillation. I think you guys are going to really like what he has put together because it's a kind of no-nonsense, practical way to approach anticoagulation and atrial fib, and he has some really cool cases to walk through. So I think it's going to be good. I think it's you're going to enjoy it. It's all you, Mom.
Awesome.
Thank you.
So they can see my presentation.
So you'll control it from here, but that's what they say. Yeah.
Okay.
There's like a 2-second one.
All right, good afternoon, everyone. So again, my name is Mohammed Osman. I'm one of the clinical cardiology fellow here at Ruby. So today we're going to talk about basically an overview of the anticoagulation in patients with atrial fibrillation. So I'm going to touch on the indications for anticoagulation in patients with AFib and to identify and classify the most common available oral anticoagulants and how do we manage anticoagulation in specific patient population, which is usually troublesome for the clinician, which is a patient with dual antiplatelet therapy indication at the same time as anticoagulant therapy indication. So to start with, we're going to start with a case. So Jamie is a 72-year-old female. She has a new diagnosis of non-valvular atrial fibrillation, and we are going to talk briefly about what's valvular and what's non-valvular AFib. Her history also includes hypertension and congestive heart failure. I think this is a common scenario that we face in daily practice. So the question will be, is Jamie at a high risk of a stroke? Does Jamie need anticoagulation therapy or not? And to answer that, we need to be familiar with basically the CHADS-VASc score. Now, CHADS-VASc score is actually a score to stratify the risk of a stroke. Now, some of us maybe heard about the CHAD score, but that has been actually updated to include the VASc component. So C stands for heart failure, and that gets 1 point. H for hypertension gets 1 point. Age gets 2 points for an age more than 75 years, and 1 point for a 65 to 74. Diabetes get 1 point. Stroke, TIA, or thromboembolism get 2 points. And basically, the new components are the vascular disease. So by vascular, we're talking about peripheral vascular disease, history of MI, or any reported atheromatous plaque, let's say on a CT done for a CT chest. And then we have the gender. So a female gender gets 1. On the right side of the screen, you see how does the score help you. So basically, the score predicts your risk of a stroke. And I think that's a very useful component when you talk to the patient and counsel them about the importance of anticoagulation and the risk of stroke. So if we apply that to our lady here, so Jamie is a 72. So her gender, female, will give her 1 score. Being 72, she's going to get another point, so that's 2. And she has congestive heart failure and hypertension, so 2 more points. So her total points is 4. So when we talk to her, we're going to tell her like her stroke risk per year is about 4%. And that's a clear indication for anticoagulation. So as per the guideline, if you're following ACC, ACP, AHA guidelines, Heart Rhythm Society, that they all agree on the fact that patients with AFib with a CAD-VASc score of 2 or more require anticoagulant therapy. So based on that, she needs anticoagulation. Now, the second question will be, what type of anticoagulation she needs? Now, we're blessed actually to be practicing medicine now in 2020 because we have like a lot of options of oral anticoagulants apart from the traditional one, which was warfarin. So we have now dabigatran, rivaroxaban, apixaban, and edoxaban. And these are the new oral anticoagulants, NOACs, or you can call it direct oral anticoagulants, DOACs, or non-vitamin K oral anticoagulants. Now, how do they work? So they are direct inhibitors of 10A or a direct thrombin inhibitors in some part. So basically, rivaroxaban, apixaban, and edoxaban. So anything end by X-ban, basically it inhibits the factor 10A, which is a common factor in the common pathway, which is responsible for the conversion of prothrombin into thrombin. Now, the only direct thrombin inhibitor which work in a different way is dabigatran. That's the only one available in an oral format at the current time. I'm going to just touch briefly into dosing. So basically, rivaroxaban dosing in atrial fibrillation. So remember, the dosing in AFib is different than the other indications, which is commonly the DVT PE indication, because in that patient population, you usually need a loading dose. But for the AFib patient, you don't have to load them for 3 weeks. So basically for rivaroxaban, you start with 20 milligram once a day. Apixaban is a BID medication, so the patient has to take 5 milligram twice a day. And we're going to talk about dose modification, because for some patients, we will actually reduce the dose from 5 to 2.5 milligram twice a day. And then dabigatran is 150 milligram twice a day, and edoxaban is 60 milligram once a day. Now, all these came, after rigorous randomized controlled trial studying each one of them against warfarin. And each one of these medications showed non-inferiority in terms of ischemic outcomes and superiority in terms of bleeding. So basically, we're talking about less bleeding with the same or better ischemic prevention. Now, a very important actually point that whenever we manage these medication and these patients with atrial fibrillation, keep in your mind, all the RCTs, all the studies actually ruled out or excluded patients with end-stage renal disease. So we usually get into dilemma when we are dealing with an end-stage renal disease patients. Now we do have recent studies within the last year which shed some or more light into this aspect. But in general, basically, for rivaroxaban, if the creatinine clearance is less than 15, so if you are talking about a patient with a stage 5 CKD or a patient on end-stage renal disease, usually the recommendation is to avoid rivaroxaban. Now, for apixaban, the company was claiming that it's safe in end-stage renal disease. We didn't have data from RCT until recently last year, and the RCT is relatively smaller compared to the original RCT. But overall, apixaban is safe in patients with end-stage renal disease based on the clinical experience and the RCT trials. Now, keep in mind that for apixaban, we need to reduce the dose to 2.5 milligram if the patient is meeting 2 out of 3 criteria. So if the patient is older than 80, or actual body weight is less than 60, or a creatinine is 1.5 or greater. So if the patient is meeting 2 out of these 3 criteria, we need to reduce the dose from 5 milligram twice a day to 2.5 milligram twice a day. So basically, most or all of our end-stage renal disease usually will have a creatinine more than 1.5. So if they meet another criteria from the other 2, they will require the 2.5 milligram dose. Now, for dabigatran and for edoxaban, both are not recommended to be used in patients with end-stage renal disease. So basically, for these patients, you end up with 2 options, either Coumadin or apixaban. Now, if you read on the literature, you're going to find here and there some data about Xarelto or rivaroxaban, but that's not quite strong as the data for the apixaban. Now, let's apply an algorithm. So we have Jamie here. We already talked about the fact that she had a high risk of stroke and she requires anticoagulation. Now the question, does she qualify for a direct oral anticoagulant, or we need to put her on Coumadin? Now, we will follow this algorithm. So basically, all the direct oral anticoagulant were actually studied in patients with non-valvular atrial fibrillation. So what's valvular atrial fibrillation? Basically, valvular atrial fibrillation is any patient with rheumatic mitral stenosis or mechanical bioprosthetic valve or mechanical valve, basically. So these 2 categories of patients were excluded from the RCTs, and we don't have any data for the efficacy of direct oral anticoagulants. So in these 2 patients population, we will still use Coumadin. Now, pregnancy or breastfeeding, still we have lacking data for the safety of the direct oral anticoagulant. So for a pregnant woman, Coumadin is still the drug of choice. So if I tell you basically Jamie doesn't have any valvular heart disease, she doesn't have any mechanical aortic valve, and she's 72, she's not pregnant at the current time, she's not breastfeeding, so that's mean automatically the next question will be what's her creatinine, what's her kidney function, is she in the stage renal disease or no? And she's not having in the stage renal disease, so that means she qualify for any of the direct oral anticoagulant. Now, there's very few data comparing the new oral anticoagulant head-to-head. There's actually no RCT comparing directly these new oral anticoagulant head-to-head in the patient population of atrial fibrillation. So at the current time, we assume each one of them has the same efficacy compared to warfarin and compared to each other. Now, so basically for Jamie, she qualified for direct oral anticoagulant. You can start her on any of the 4 medications, and that can be started at the office. You don't need to admit her to the hospital for bridging or anything like that. Now I'm gonna touch on patients on dual antiplatelet therapy. Now,
So you want to go back there?
Sure.
Because I think people, I think one thing you had in there is about the ability to pay for the drug.
definitely.
And I think that's something that's really important that we need to discuss. There's patient assistance programs that we have available that the companies provide. So that's really important to understand. So, those things, I think, you need to talk to the patient about, but there's definitely materials that the company can give to help pay for the drug.
Definitely.
And I know our clinic, we're lucky enough we have a social worker who helps us with those kinds of things, but the prior auth for those kind of things are not horrible for the DOACs, but I think it's something that's really important to keep in mind. Medicaid, they're covered, so that's not going to be a problem for, that's a lot of our population. Medicare, it begins to become a problem when they hit the donor hole, so that's definitely an issue. So something that I would not ignore, and something that you absolutely want to discuss before you start the drug. Because I can tell you, a lot of patients, it's not discussed with them, and they come and they say, this is I'm seeing them for heart failure, and they end up telling us how much, there's some medications that will start can cost, and they say, well, my Eliquis or my Xarelto is already costing me, $170 a month. Is there anything you can do? So those are things I think are really important to talk to the patient about.
Totally agree with that. And I think I want to say that we have like 30-day free supply, right? Usually for all of these oral anticoagulant, and the process basically of approval tend to be easier now compared to the past. So we're going to move to the patients on dual antiplatelet therapy. So these patients usually pose a challenge for us, to be honest. So let's take a scenario here. So James is a 77-year-old male. He had the recent diagnosis of non-ST segment elevation myocardial infarction about a month ago, and he was treated with that with a drug-eluting stent to the left anterior descending coronary artery. He also has hypertension and stroke, and he's currently on dual antiplatelet therapy with aspirin and clopidogrel, and he's on lisinopril 40 mg for his blood pressure. So he presents today to the office complaining of fast heartbeats. Now, remember, for patients who had recent stents, we need them to be on dual antiplatelet therapy for a year, preferably, or minimum 6 months. Now, this is his EKG, and basically the EKG showed irregular rhythm with absence of P wave, which is basically the classical of atrial fibrillation. Now, what do you think is the best treatment strategy? So we know now he has high CHA2DS2-VASc score, so he has a high risk of stroke. At the same time, he needs to be on dual antiplatelet therapy because of his recent stent. Should we continue the aspirin 81 mg and clopidogrel and just call it a day? Dual antiplatelet therapy may help him with the stroke, so why should we add another blood thinner? Should we stop the aspirin 81 mg and continue clopidogrel 75 mg with the addition of oral anticoagulant for stroke prophylaxis? Should we continue aspirin 81 mg and clopidogrel 75 mg and then start oral anticoagulant for stroke prophylaxis, and this is what we call triple therapy? Or should we increase the dose of aspirin to 325 and continue the clopidogrel 75 mg? So basically,
What does everybody think?
Feel free to chat it in too if you don't want to unmute yourself. Option 2 says one.
everyone.
And we do have a question when we're done with yours.
All right. Fantastic. Actually, the correct answer is option 2. So nowadays we have a strong data supporting actually the dual therapy approach compared to option 3, which used to be the correct answer maybe about 5 years ago when we didn't have enough RCTs to support dual therapy. So basically the message that I'm trying to send, no more triple therapy after PCI for patients with atrial fibrillation. And this comes basically from, so this is basically one of the meta-analysis for all the RCTs. So it comes from 5 strong RCTs, which studied actually all the different new oral anticoagulant. The most recent one was Entrust. So if you look, you can see that there is no difference between dual therapy and triple therapy in terms of MI or all the other ischemic outcomes, including stroke or stent thrombosis. And if you look at the major bleeding, it definitely favors dual therapy. So patients who were placed on triple therapy had higher chance of bleeding. So the message is that no more triple therapy, and these patients can be safely treated with dual therapy, which include an oral anticoagulant plus a PTY12 inhibitor. And on these trials, like I would say 92 to 95% of the patients were actually on Plavix. So we have stronger data to support clopidogrel and Coumadin or clopidogrel or plus any of the new oral anticoagulant compared to the other stronger PTY12 inhibitor like ticagrelor or Darlinta or prasugrel. And I think that conclude my presentation, and we're happy to answer questions.
Sure.
That was wonderful. Thank you so
Thank
much.
you.
And thank you for including some of those cases. That's really helpful and things like this.
Yeah, so I think if you guys have any any cases that you want to run by us about not clear what you want to use, that kind of thing, I think we'd be more than happy to talk about that.
We did have one question during the presentation, and so it was does warfarin have better coverage for Medicare, and how about the continuous labs that are required for that?
So definitely, definitely going to be covered. It's definitely going to be cheaper from just the drug standpoint, but that's where when they do the cost effectiveness on these medications, not having to draw the labs, the INRs, that's where they make up the cost on the back end. So that's why most insurers are starting to cover them more easily. So that information is definitely there.
And I know you answered this a little bit at the end, but do you guys have a first course that you try to go with, or is it all per patient?
I think we usually leave it to them. We try to individualize it as best we can. I mean, I will say that I'm a little biased towards apixaban because there's some data that suggests there's less bleeding risk with apixaban over rivaroxaban, but doesn't mean the other drugs are not effective for this. But if I have someone who I think may be a somewhat higher bleeding risk, I lean towards apixaban because of that, mainly GI bleeding, but that data is there.
I definitely agree with that. And then also, like, what plays a role is compliance. Like some patients don't like to take twice a day medication. Like for them it's difficult to take apixaban twice a day. So in that patient, for example, you can option to give Xarelto because it's a once a day pill.
Now it's that second case that you presented. They should have been on vehicle.
Mm-hmm.
Okay.
Just saying.
Yeah. and a atorvastatin.
I have a patient. The patient has a CAD and history of thrombotic stroke. The patient also has like a polymyalgic rheumatica, and the patient suffers with chronic anemia. Now, the patient had that colonoscopy, endoscopy, and even hemorrhoid ligation, and there is nothing, signs of active bleeding. Okay, and
We're still here.
the patient seen by hematology, and they diagnosed him with cirrhosis. Now, the patient does not have any.
Sorry.
We're still here.
We're still here.
Yeah.
The camera moved on us.
Okay, that's one. And the patient recently diagnosed with cirrhosis, like they did a blood work and it shows that fibrosis F4 score. The patient does not have any underlying condition that predisposed to cirrhosis. And I mean, other than, so far, so it's a new. Now, the patient's hemoglobin is around 8 or 9, and the patient had been admitted in the hospital in the past because his hemoglobin went down to 8 or less, and he was symptomatic with stroke. And at that time, it was not like a thrombotic stroke. The only thing I can think of, was probably anemia on the top of the other things that contribute to the stroke, because he recovered completely. Now, the patient was on aspirin Plavix, and when he had the stroke second time, the heart doctor recommended changing Plavix to Xarelto, 2.5 milligram, because it is FDA approved for the prevention of stroke, CAD. Okay. Now, his hemoglobin is still like, I have to closely monitor. Okay. And we are still struggling. My question to you is, right now the hematologist mentioned that with his current condition of cirrhosis newly diagnosed, he should stop Xarelto. Okay. So my question to you is, right now, what would be the best option? And the second question I have is, I was trying to see if the patient can continue with aspirin and Plavix, and if I can keep an eye on the hemoglobin and it's not going below 8, can we just continue with that? Or is there something bound to fail? And I have to tell patient to be off Xarelto, Plavix.
Well, I think the bigger question is, why do you need aspirin and Plavix? And if the answer to that question is for secondary stroke prevention, that's one thing. If you absolutely need something for anticoagulation for atrial fibrillation, and you continue to have bleeding, that's a contraindication to anticoagulation.
No, he does not have atrial fibrillation. I mean, right now, it's more like between CAD and the stroke prophylaxis. So he was on aspirin Plavix, but he still had stroke while on it.
So has the patient had stents placed?
Yes, in the past.
How long ago?
I mean, I'm talking about more than 5 or 7 years ago.
Yeah. So I mean, the data there would suggest that you don't necessarily need dual antiplatelet therapy as a general rule. Kind of depends on where the stents were placed and if there's difficulty in the procedure. But in general, I mean, the recommendation is, especially if you're having bleeding problems, dual antiplatelet therapy, that's not an indication for it. However, the stroke, for stroke, I mean, neurologists, and there's data to suggest that you may use it for that. But I think you have to, if you're going to use Eliquis, it's not going to be for coronary artery disease. We're not going to use it for that. If you're going to use it for secondary prevention of a stroke, if you think it's thromboembolic, you have to have some sort of proof. But that's just, a good thing to have that on the data that we have.
I mean, it was Xarelto 2.5 milligram actually. I mean, the heart doctor showed me the study also. I forgot the name of that, and even FDA approved it for the CAD and stroke prophylaxis.
Yep.
So he tried to substitute the Plavix with the Xarelto 2.5 milligram daily.
He's correct.
In addition, I thought you meant in addition. I'm saying you're not going to do that in addition to those meds.
No, he substituted it for Plavix. So basically aspirin. And so he's right, like Xarelto at a dose of 2.5 is actually approved for that, and it's approved even for peripheral vascular disease and PAD patients. Now, the question, does the patient has atrial fibrillation? Are we doing that for EFIT?
No.
Okay, so
that's what I'm saying. It's a different indication, right? That's why I'm trying to understand when everything was and how recent everything was. It kind of determines what you do.
So this patient is definitely at high risk of bleed. What I would do, I would have an individual discussion with the patient, hey, your risk of bleeding is so and so based on the calculator. Like you can use HAS-BLED, for example. I'm pretty sure you mentioned liver cirrhosis. So maybe is he old? Like, are we talking about 70s or?
Yeah, he's in 70s. But
that definitely, these two factors together, like age plus liver cirrhosis, will put him at extreme high risk of bleeding. And we already have history of bleeding with low hemoglobin and pretty sure blood transfusion. So these together put him at a higher risk of bleeding. So basically, when we weigh the risk and benefit, his risk of bleeding will be way higher than the benefit of basically anticoagulation. So I would talk with the patient directly and then basically give him the data. Hey, you're high risk of bleeding. We want to do something good, but if we try to put you on blood thinners, we increase your risk of bleeding. And then I will, reach a conclusion with him to leave him just on aspirin. I wouldn't even put him on DAP, to be honest, because the data about bleeding on DAP, dual antiplatelet therapy, like the rate of bleeding is almost the same as like the new oral anticoagulant. So in that case, I will just leave him on aspirin and let it be. Our task is do no harm. If we cannot do anything, I will just leave him on monotherapy. But that's just my opinion.
Yeah, I agree. Because whenever you start leaving on those medications, you want to make sure what's the benefit you're going to derive out of it, right? I mean, we want to show you already have what you described is a bunch of other problems with that patient, and that sounds like they're going to have more significant issues with their secondary problems than with their CAD.
And the CAD is 5 years ago, so he doesn't need dual antiplatelet.
Right.
Okay, thank you. Thank you so much.
Right, and the rivaroxaban
Thank you, Dr. Polywell.
Was how long after that was stented CAD, right?
So rivaroxaban, the study,
I can't remember.
What was the name of the study? That was
The COMPASS trial?
COMPASS, right?
Yeah.
So COMPASS had two arms. One of them is peripheral vascular disease, and that where they showed actually the benefit, the true benefit.
Right.
So actually, the Xarelto benefit on CAD was marginal, it was not strong. There was a benefit, definitely, but when you compare it to the peripheral arterial disease population, these are the patients who got most of the benefit. So we don't use it here, typically, like the 2.5 milligram, we don't resort to that. But he was right. There's some data supporting the 2.5 milligram, definitely.
It's pretty weak. I'm not gonna lie to you. I mean, I put it in my own brain category as not beneficial, just because I don't think it's worth it.
Yeah.
But I'd be lying to you if I said there's no data at all. But there's certainly no data at all to add it in addition to doing it.
To do an antiplatelet.
We had another question submitted. It's similar to what we were just talking about, but it says, is there any benefit to continuing anticoagulation for AFib in patients at the end of their life or on hospice? Some of these patients really like holding on to those medications.
Yeah. I guess come from Charles, right? So Charles, I think that in my mind, if we're there and we know that, because all the benefit out of using these are for long-term stroke prevention. So I think stopping them is appropriate, absolutely appropriate. And that's in the hospice setting, for sure. Great question. I think we sometimes forget about that. We get so caught up in doing everything else for the patient that sometimes we forget about that aspect, and that's why we're lucky to have you to help us with that.
Did anybody have any other? Oh yes. Perfect timing. Heard in the past, if an oral anticoagulant is needed when an inferior vena cava filter is placed. True. Yes. I didn't know.
So usually IVC filters are placed in patients who
cannot tolerate
okay. Oral anticoagulation because of their risk of bleeding. So
yeah, I mean the other one, another time they place is in trauma situations, so that the trauma surgeons oftentimes will place an IVC filter in massive trauma. But those are typically removable filters.
Okay, and those would not be used at the same time.
Not typically.
Thank you.
So let me be clear. The other time some IVC filters are sometimes used is if people are failing anticoagulation. So it doesn't mean you stop anticoagulation in that population, but that's an additive therapy to anticoagulation. So let's say recurrent pulmonary emboli in patients who on oral anticoagulation, you can consider using it in that situation. But the benefit there is not exactly robust.
You guys can't see them, but they're in the room with us. Mary and Rachel are over here. So if you guys do have any farm or additional questions and stuff, you're welcome to ask them. They can see you, but if I move the camera, it'll fall. So.
And another question, if you don't mind.
Yes,
I mean, I had a patient who was on, I think, Eliquis or Xarelto for atrial fibrillation. And the patient has to be off anticoagulant for 2 days for a dental procedure. And she had a stroke, okay? But incidentally, she was caught during the daytime and she got the clot removed by embolectomy and she recovered completely. It just arises in my mind is that if we really have this kind of high-risk patient where we cannot take them off anticoagulation, giving them something like Lovenox for a day. I know the Xarelto and Eliquis, they say you have to be off for 2 days. But do you think covering them with Lovenox for 1 more day has some benefit? I know there is no indication and there is nothing like they say. But if you want to be just more safer, will it do any good or it's not even worth trying?
I mean, we don't typically do that because, the risk, remember, we're talking about the risk of stroke in most patients with atrial fibrillation. It's a risk over a year. And, anticoagulation in general, you think about 6% a year. And so, I mean, the risk over a couple of days, while it happened to that patient, I typically don't add any other type of anticoagulation. I can, this one I'll punt to my pharmacist, but I think as far as I think the benefits, there's no study to show that anyway.
Yeah, I think ultimately all the data comes from the Bridge trial years ago, which showed the increased risk of bleeding surrounding those who were bridged with either Lovenox or heparin. There is some data from I think ACC has a couple of references to utilize in terms of what the risk of the procedure is. and then weighing that against the risk versus benefit for being off anticoagulation for a period of time. So there's nothing that you can really do from an all-encompassing standpoint. It's really just a comfortability between those two kind of balances. And really, again, the only data is pretty old from the bridge trial many years ago for those elective procedures.
Okay, great. Thanks.
We did have another farm question. Are there any anticoagulants to pay particular attention to for patients on methadone?
Not that I think of offhand from any drug interaction or any other standpoint.
Okay, great.
Yeah. You know, it is interesting, but we have an MAT echo as well, and we actually do end up with a lot of patients with heart problems. We can cross case consult. All right, guys, do you have any other questions or anything before we end? I really appreciate you all showing up. We had a great group today. Our next cardiac call is going to be on the 21st, and Dr. Kakmo is going to be giving the didactic that day. I don't remember what it's about right now, but I will send it in the recap email, so keep an eye out for that.
I think it's pulmonary hypertension. He's talking about.
Pulmonary hypertension, there we go, works for me. If you guys have any questions or cases about that, please feel free to submit those or just email me and we'll make sure they're on the agenda for that next session. And if you have any remaining questions that you think of after the end of this one, we'll make sure that Dr. Osman gets them. So everybody have a wonderful day.
Thank you.
Thanks,
Thank
everybody.
you.
Thank you.
Great job.
Thank you.
Very nice.
Thank you.
Thank you so much, that was
Thank
great.
you.